Hello, welcome to Cardio Flash College, a place to learn cardiology with flash animations. Today we continue with our weekly section Flash Code, a place to explore the world of acute coronary syndromes and primary angioplasties. Let's begin. This week we have a male patient of 57 years old, smoker, without other cardiovascular risk factors or any background of interest. He arrives at our unit with a diagnosis of ST segment elevation myocardial infarction, also known as STEMI, with an evolution of approximately 2 hours. His clinical situation is stable, but chest pain persists. This is the electrocardiogram of our patient. As you can see, it is evident the existence of changes on the ventricular repolarization. These alterations express as elevations or descents of the ST segment in some leads, and they suggest an acute myocardial lesion. Could you identify these disturbances? That's it! In this electrocardiogram, we have an elevation of the ST segment on the inferior and lateral leads, with a mirror image descent of the ST segment on V1 to V3 leads. This tells us that we have a subepicardial or transmural type of acute myocardial lesion on the inferior and lateral walls of the left ventricle, what is known as inferolateral STEMI. But what clinical relevance does this have? Very simple. ST segment elevation myocardial infarction is the regular clinical manifestation of a complete blockage of a coronary artery and constitutes a cardiological emergency where every second counts. In this way, our main objective is to open the artery as soon as possible, whether it is using fibrinolysis or primary angioplasty. In this case, primary angioplasty was performed. As you can see, right coronary artery is open and it does not present any significant lesions. Let's take a look at the left coronary tree. The first observation that calls our attention is a greatly developed artery that tours the anterior wall of the left ventricle and gets to the apex of the heart. We are talking about the anterior descending artery, and as you can see, it presents several lesions on its middle segment, some very severe and complex, but the artery is open, so it is probably not the one responsible of this infarct. We must seek out the closed artery, an artery whose journey also coincides with the infarcted territory. Have you found it? Congratulations, nice job. We are talking about the circumflex artery, or what is left of it. For those of you who have not seen it yet, do not worry. It is not easy to see it on this perspective. It is the stump that is located on the superior side of the image. Do you see it now? Let's see another perspective. Using different perspectives, we can see the circumflex artery blocked at its proximal segment. We only need to treat it now. First, we need to pass an angioplasty guide wire through the obstruction. Sometimes, as in this case, passing the guide wire partially opens the artery and allows us to see the distal branches. In this case, the next step was to implant a stent on the blockage zone. This props the artery and returns blood flow. And this is the final result. As you can see, we have recovered the blood flow of the artery after implanting the stent, obtaining a good angiographic outcome and without pre-procedure complications. In this way, with the artery open, the ST alterations are progressively improving and pain disappears, being this emergency resolved, and with it, our chapter. It has been all for today in Cardio Flash College. We hope you liked the video. If so, subscribe to the channel and leave a like. We'll see you in the next class. And remember, don't come late. Bye!